All right, welcome to our next witness. Welcome, sir, to step forward. And in the meantime, we'll swear on the witness in. Welcome, sir. Just watch your step and raise your right hand for the trial clerk, right here.
Do you solemnly swear or affirm that the evidence you're about to give will be the truth, the whole truth, nothing but the truth?
I do.
Wonderful. Make yourself comfortable in the stand, sir. And there should be water up there for you as well. All right, whenever you're ready, Ms. Schneider.
Yes, Your Honor. May I please please the court?
Thank you so much.
Your Honor, good afternoon, ladies and gentlemen. May I approach the witness to give him some
Of
water?
course, absolutely.
Good afternoon, Dr. Rob.
Hello?
You're going to probably be talking a lot, so you may need some of that.
Okay.
And we're going to go about 20 minutes, and then we'll take a short afternoon break as well.
Sure, Your Honor. Thank you so much. All right, Dr. Rob, would you please introduce yourself to the jury?
I'm Dr. Stephen Robb.
Are you a medical doctor?
I am.
What kind of doctor are you?
I'm a pathologist.
Do you have specialties in pathology?
I do.
Oh, go ahead.
I'm a anatomic pathologist, and I'm a cytopathologist with board certification in both of those.
Over the course of your career, Dr. Rob, have you developed a specialty in the misdiagnosis of cancer?
I have.
And as a pathologist with a specialty in the misdiagnosis of cancer, are you here today, Dr. Rob, to testify about whether Mrs. Adamson had primary lung cancer?
I am.
Now, are there several medical records in this case with references specifically to the phrase lung cancer?
Yes.
Dr. Rob, did you see anywhere in the medical records where any doctors suggested that they believed Mrs. Adamson's cancer started outside of her lung?
I don't see reference.
Go ahead.
I don't see evidence of their actually stating that in the medical record.
So now, based on those two things, can we just call this a primary lung cancer and go home?
I don't think so.
Why not?
Because I believe that although there is a complete lack of, to me, medical record evidence from when the diagnosis was made, I think that the lack of this evidence makes it a very difficult call to make of where this tumor came from. And there are data that I think within the depositions and within the medical records that do exist, as well as in the calendar that we have that could point towards there being another source of this tumor.
Dr. Rob, is that what we're going to spend our time here today talking to this jury about? Your opinions on that?
Yes.
As a pathologist specializing in the misdiagnosis of cancer, have you looked extensively at the issue of whether treating physicians got it right or whether there's another explanation?
Yes.
Dr. Rob, do you understand that this is a tobacco case?
I do.
Are you here to testify today about smoking in any way, whether generally or as related to Mrs. Adamson's case?
No.
Are you here to testify today about the possible causes of Mrs. Adamson's cancer?
No.
Do you understand that there's another witness who will talk about Mrs. Adamson's risk factors for cancer?
I do.
Is this your first time as an expert witness at a tobacco trial?
Yes, it is.
Well, we'll try to make you a little comfortable, okay? So let's step back and have you give the jury some background information about your qualifications.
Okay.
Should be an easy question. How long have you been a doctor, Dr. Rob?
Well, I actually graduated medical school in 1988, and so I've been I did 4 years of training after that, and since then I've been practicing for 25 years.
Now, you're the first pathologist that the jury has heard from. Can you please explain to the jury what a pathologist does?
Well, pathologists have a lot of roles. One of the major roles that we have is looking at tissues and fluids to make diagnoses. And one of the main things of what we do in that is actually make diagnoses of cancer or make diagnoses of not cancer, and then subclassify different types of cancers and describe those in a number of ways.
Now, you said you had specialties in anatomic pathology and cytopathology. Can you please tell the jury what those are?
Well, anatomic pathology actually encompasses the domains of what we call surgical pathology, where they remove either large amount of tissue or smaller amounts of tissue, but it consists of material that we look at under a microscope, a microscopic slide. A cytopathologist is one who generally looks at very small pieces of tissue or aspiration specimens or fluid specimens, and also interprets pap tests. And they tend to look at smears and other preparations rather than whole tissue mounts like surgical pathologists do. And the last group that fits under anatomic pathology is the field of autopsy pathology, where you do autopsies to determine causes of death, or associations related to that. And a cytopathologist is again, sort of a person who specializes in doing or interpreting fine needle aspiration biopsies.
Have you worked as a pathologist in the hospital setting?
Yes, I have.
So what do you do specifically in the hospital setting as a pathologist?
Well, what we do in the hospital setting is that for both the cytopathology and the surgical pathology field, we interact with clinicians who are often obtaining specimens that help us to guide us in what we may be making diagnosis of when we look at tissues. But we generally look at tissues from patients who are in the hospital for various diagnostic tests.
So as a pathologist, do you actually diagnose cancer on a daily basis?
I do.
Over the course of your career, how many cancers have you diagnosed?
Thousands of cancers.
Does diagnosing cancer as a pathologist include determining the primary site of the cancer?
Yes.
Have you diagnosed the primary site of cancer?
Have I? Yes.
Have you diagnosed primary lung cancer?
I have.
Have you diagnosed cancer that's metastatic to the lung?
I have.
Have you diagnosed other types of cancer?
Many types of cancer.
Now, the jury has heard the term cancer of unknown primary. Have you diagnosed cancer of unknown primary?
Yes, I have.
What does diagnosing someone with cancer of unknown primary mean?
Well, oftentimes when someone presents with cancer, we may or may not know where the cancer came from. And that's because cancers can metastasize and move to other sites. So one of our goals is to be able to determine if this is a metastatic tumor or if this is a primary tumor that arose in an organ that we are looking at. So cancers of unknown origin often are widely spread, and we can't determine where the original tumor arose from. So when we talk of that term, it's often at the end stage of our working up a tumor, because we can't really come up with where it originated at the end, because it's in too many organs for us to be able to tell.
Now, as part of the reason that there are times you cannot determine the organ from which the cancer arose, the fact that under the microscope, tissue or cancer from different organs may look the same.
Yes, there are cancers that look very distinct depending upon where they're from, but many cancers share a very similar appearance under the microscope that it can be difficult to determine where that cancer may come from without assistance.
And is this especially true when you're dealing with a cell type like adenocarcinoma that can come from a number of different organs?
Yes, some adenocarcinomas have specific features that can help you to tell that, but many don't, and they just have a kind of a generic appearance that they look like. An adenocarcinoma is a carcinoma that comes from glandular structures, and they look very similar to each other.
In your experience, are you always able to figure out the organ from which the cancer came?
No, you're not.
Dr. Rob, do you treat patients for cancer?
Well, I'm involved with working with the treaters because they depend upon our diagnosis. So I would say that we actually form teams where we have different roles in what we do. And those are the times when things work the best for the patient because everybody has a role. And it overlaps depending upon what we may think or say, but I don't, say, prescribe chemotherapy or do radiotherapy, which are forms of treatment.
So through working on that team of doctors involved in the circle of care for a cancer patient, do you help guide treatment decisions through your recommendations based on your review of pathology?
Yes, I mean, oftentimes we do this informally with phone calls, or we may do it formally in tumor boards where members from the different portions of the team, and so I'm one of the diagnostic portion of the team many times, are involved in discussing malignancies, because it's actually a complex field, and you need both sides of the team, or those who sample the patient, those who know the best about the clinical side, and those who are going to treat, as well as the pathologist, before you actually probably would want to treat. You want all that input in sort of the circle or group of pathologists or medical physicians involved.
And through that experience, have you become knowledgeable about the treatment of cancer patients?
For many types, yes. So, I mean, I know if they're going to be doing, well, it's often told and it becomes, redundant what we may know, but for patients that are going to have surgery or chemotherapy, and it often depends upon the stage of cancer, which is one of the things that pathologists have a large role in staging a cancer. It's spread when it's initially detected.
Now, are you here today, Dr. Robb, to question in any way whether the treatment Mrs. Adamson was given was appropriate?
No, I'm not.
So let's talk a little bit more about your qualifications. How long have you been licensed to practice medicine?
Well, I had a training license in 1988 when I started, and that limited me to, as a trainee, what a trainee could do during those years. And then I became licensed for the first time in 1992.
And where are you currently licensed to practice medicine?
I'm licensed to practice medicine in the states of Mississippi, Colorado, and in Pennsylvania.
Are you licensed to practice medicine here in Florida?
I'm not.
Does that affect your ability at all to come in here today to testify about Mrs. Adamson's care and treatment in terms of her primary site?
I don't think so.
The jury has heard a little bit about board certification. Do you hold any board certifications?
I hold board certification in anatomic pathology and cytopathology.
Your Honor, are we still good on time?
Yeah, let's go ahead and take a quick 10-minute break so I can take care of some other cases. We'll take a 10-minute break and then we'll continue with this witness.
Thank you so
Chris.
much, Your Honor.
We don't agree with their couple of these drawings, it's argumentative, they don't think that foundation, I don't think he was disclosed as an expert about these lines with the heads and where things are going.
This is just a relationship. I assume this is just a demonstrative.
Yes, Your Honor. He was asked a lot in his deposition about what access to records what the doctors would have had. This is just a demonstrative to the transfer of information. He's an expert in communication failures that occurred during the treatment.
Except his testimony was he has no idea who was communicating with whom or what was happening. That's my concern about this picture.
That's exactly
That's the point, isn't it? That he doesn't.
I don't know.
Okay, I'm not overruled.
The other thing, too, Your Honor, I don't know if this is going to come up or not. He's obviously published papers about disagreements with pathologists and all that on his CV, fair game. He has an ongoing study that hasn't been published that he's trying to get funding to do additional studies on. That involves right now just one facility, the University of Mississippi. And I don't think I don't know if you're planning to go into that study or not.
I'm not planning to go into any studies, Your Honor, or specific studies. I'm just asking what his overall opinions are based on his research and experience.
If he's going to, so his opinions on it that are in his published literature set the error rate or disagreement rate at 15 to maybe 20%. This new thing he's doing in Mississippi, suddenly it's 40%. And that's based on evidence that should be, it's not published, it's not peer reviewed, it's an ongoing
Ms.
study.
Chambers said she's not getting into it.
But if he says 40%, then that's where it came from.
Well, I don't know what he's going to say.
Yeah,
so.
and I disagree with
Okay.
that. So.
disagree, if he says, well,
He might have another basis for it.
Yeah, he has a
well,
number
I
of
guess
other-
I guess we need to, that's not something that's been disclosed, and I've read all of
He
his
wasn't
papers.
disclosed on his error rate?
On his studies that
Okay.
he's published, yes, but if he's going afield into other people's studies, and that's an area that we weren't providing,
Okay.
then if he's
I'm just
relying,
saying he's not.
okay, but then if he's relying on this thing he's doing in Mississippi, then he shouldn't go to that because it's not published.
She's
not
saying
here.
she's not getting.
He was giving his overall opinion
Based on
about the
that,
earring.
based on that study, yes.
I don't think that that particular study, there's a ton of studies, I mean, tons.
That's the only one
I'm not
that's
asking you about
outside of
specific
20%.
studies.
You can ask him cross-examination. I don't think he's going to get into that particular study.
I hear the point.
Okay, all right.